evening, everybody. Welcome to our ICD webinar twice monthly. Okay, so tonight we will go on with our last program for the month of September. Everybody, welcome to our ICD webinar. And tonight, our speaker, the moderator for this session is Associate Professor Dr. Masurialis. She is the Deputy Dean of Student Affairs at UITM, Faculty of Dentistry UITM, and also the Director of Head of Program of Special Needs Program at UITM. So without further ado, I will invite Associate Professor Dr. Masurialis to introduce the speaker and begin the session. Mas, over to you.
Okay, thank you, Professor Dr. Muhammad Ibrahim Abu Hassan. Okay, hello everyone. Welcome to ICD Section 15 webinar session. My name is Mas and I'm your moderator for tonight. We are very honored to have our esteemed speaker, Associate Professor Dr. Yoshinobu Shoji, or as we call him, Prof. Nobu, to share his experiences and knowledge in his area of expertise. And before we begin, let me just introduce Prof. Nobu to everyone. Prof. Nobu graduated with a Doctor of Dental Surgery degree from Matsumoto Dental School, Japan in 1983. He then pursued his Master of Dental Surgery in the University of Sydney, Australia in 1992 and Clinical Fellowship in Temporomandibular Disorders and Facial Pain at the University of Medicine and Dentistry of New Jersey, USA 2 years later. Prof. Nobu is a diplomat of the American Board of Orofacial Pain since 1996. He is currently an associate professor at the Faculty of Dentistry, University Technology Mara, Malaysia. He will be delivering a talk entitled Non-Odontogenic Toothaches, Dilemma in Management of Orofacial Pain. Please welcome Prof. Nobu.
Thank you for your kind words, Dr. Mas, and good evening, everyone. Today, I like to share something about orofacial pain. So title is Non-Odontogenic Toothaches, Dilemma in Management of Orofacial Pain. Okay, I hope you enjoy that. Yes. So, first of all, I want to present the definition of oral health by FDI. Oral health is multifaceted and includes, there are three. One is the ability to speak, smile, smell, taste, touch, chew, swallow. So recently, difficulty in smelling or tasting coming up by COVID-19 pandemic, as you know. And second one is convey a range of emotions through facial expressions with confidence. So, as you know, the aesthetic dentistries are coming up anywhere in this world, I think. And third one, it's the point of today. Without pain, discomfort, and disease of the craniofacial complex. So no pain, no discomfort, but it's not only from the tooth or gums or surrounding structure. All of the craniofacial complex means all of the structures in stomatognathtic system. All right, these three are the definition of oral health. So happiness is patient who has wide mouth opening. So it means what I'm saying is we need to care about the tooth or gums and something in the mouth, but not only intraoral structures, but also extraoral structures, including temporomandibular joints, right and left, and masticatory muscles, and nerves and vessels, and so on, to make them happy, I think. All right. So learning outcomes, there are three. You will be able to classify the common orofacial pain and identify the non-dental causes of toothaches. I'm going to explain about that. And describe suitable clinical examinations and assessment for orofacial pain. So how to evaluate. Okay, these are learning outcomes of today's lecture. Okay, So I put the dilemma, otherwise dilemma, in the title. But what the dilemma is, according to the world famous textbook by Oacial of Kentucky, Bell's orofacial pain, and so on and so on. Pain from an obvious cause, such as a toothache, is managed with no difficulty by dentists, right? When a pain occurs spontaneously or without structural cause, the clinician may become confused and frustrated. This is what they said, what he said. So when the patient complains pain, but if we cannot see any structural cause like a cavity or caries, and so nothing is wrong, but they complain pain. At that time, clinician may become confused and frustrated. Do you agree? Yeah. So let's talk about dilemma in our daily clinic. Okay, tonight I'm going to show you a case, one of my recent cases, because I think it's easy to understand what's happening in the patient with chronic orofacial pain. Following the case, I think it's easier to understand. So this patient referred from the otolaryngologist, it referred by the clinic of Faculty of Medicine, UITM. So we are, in the same campus, medicine and dentistry. So it's referred from next door, okay? 22-year-old female, basically healthy receptionist. Chief complaint, there are three. One is toothache of lower right, she said. It's the most biggest problem. And second, pain in the right side of her head, face, ear, and neck. All of the head and neck on the right side. And third, difficulty in opening and chewing because of pain, she said. So this kind of multiple complaints are typical in the case of chronic TMD or orofacial pain. But anyway, problem sounds like problem is in the right side of her head and neck, face, neck, all right? So let's see, history of present illness. What's happening is the pain started in the lower right side of her face 9 months ago without any event. So it's been already a 9 months. So if it's more than 3 months, usually we call it chronic pain, okay? Before 3 months, it's acute maybe, but after 3 months, it's chronic. So it's already chronic. And without any event means she didn't have any events such as traumatic accident, automobile accident or something like that. Pain just started about 9 months ago. And according to her dull aching pain complaint, root canal treatment, RCTs, root canal treatments were performed on tooth for 6, but the pain did not resolve. That's the problem in the past. As you can see, the root canal treated tooth for 6. For me, it looks okay, but anyway, she still complained pain after the treatment, okay? Then recently, the pain has spread to her head, neck, and right ear, especially to the ear with poor sleep. The pain spread out, she cannot sleep well because of pain, she said. And it's getting more and more, worse and worse. Then she was referred to ENT, ear, nose, throat, otolaryngologist, specialist for her right ear pain, and suggested to see an orofacial pain specialist by ENT specialist. So it means she had a treatment by her dentist, endodontist, and she complained pain, and she started to complain earache as well. So this endodontist referred her to ENT specialist in a medical clinic. But ENT specialist said nothing is wrong in the ear on the right side. So it's better to see orofacial specialist. So she came to next door to the UITM Dental Center to my clinic. That's her, history. So she has pain on the right side, as you can see in the figure, not only teeth, head, ear, neck, so on, so on. Is it okay? Is it clear? So this is a letter of referral from ENT specialist. So from otolaryngology, UITM Faculty of Medicine, next door, just next door, okay, to dental officer, and came to me after that, okay. It's the beginning of this year under the MCO pandemic, and referral reason, C/O maybe complained of right jaw pain since March 2020. So it's January, so about 9 months ago, it already started, and pain is getting worse or spread out, and unable to open mouth wide and chew properly. Yes, maybe. And tender right TMJ, it's a temporomandibular joint, I think. And TRO. Okay, this kind of letter from especially medical doctor usually makes us confused because lots of abbreviation. But TRO, I think to rule out, right? TMJ tendonitis. So this ENT specialist is very kind. She already suggested a kind of differential diagnosis. It might be TMJ tendonitis. TMJ tendonitis means simply it's an inflammation of temporalis tendon. As you know, it's an insertion of the temporalis muscle to the coronoid process. And anyway, now we need to think about that. She had the root canal treatment of tooth 46 because she complained as toothache. And she went to ENT specialist, and ENT specialist, this might be a TMJ. So the first, maybe we're gonna talk to we discuss with the patient, the patient asks me or you or someone, is it better to redo the root canal treatment? Or is it better to extract? Or is it better to see what's happening in the TMJ? Or something like that. So, just usually frustrated in this state. And now, the rule of thumb in the differential diagnosis is toothache is the most common pain in dentistry, but other facial pain disorders may mimic the symptoms of toothache. So of course, we are seeing the toothache. Most of our patients have toothache in our daily dental clinic, but other structures also could be the source of pain. This Well-Done Bell said. It's classic textbook, all right? So in this case, we're gonna think in this way. Toothache is quite common in our dental clinic, but maybe there are two categories. One is odontogenic toothache, and the other one is non-odontogenic toothache. So odontogenic toothache is by dental hypersensitivity, pulpitis, apical periodontitis, marginal periodontitis, or pericoronitis, and so on. We are all familiar with this. But how about non-odontogenic toothache? Non-odontogenic toothache may have musculoskeletal origin. Musculoskeletal means from the muscle or joints. In this case, temporomandibular joints, right and left, or masticatory muscles. And next one, neuropathic may have neuropathic origin. Neuropathic means, neurogenic. So origin is in the nerve. In this case, usually trigeminal nerve. And neurovascular origin. Neurovascular means it's simply a primary headache because some primary headache, such as migraine, may cause toothache at the time of the attack. Okay? Then idiopathic origin. This is, as they said, totally idiopathic. There is no known cause. such as, but they complain pain, such as atypical odontalgia or atypical facial pain or something like that. Then psychogenic origin. Psychogenic origin, we still don't know exact mechanism, but such as pain, toothache, or dental pain by somatoform disorders or something like that. So anyway, there are two categories. And most of our patients, of course, they may have odontogenic origin, okay? So the point is, how do we differentiate non-odontogenic from odontogenic toothache in our clinic, all right? How to differentiate? So what we need is, anyway, comprehensive evaluation of orofacial pain. Usually comprehensive evaluation for pain in the head, face, and neck may have 5 points. First one is, as you can see in the figure, general head and neck examination. And second, joint examination, in the case, temporomandibular joints. And third, muscle examination, masticatory muscle examination. And fourth, the cervical screening evaluation. It's mainly cervical spine. Okay, I'm going to explain why cervical. And fifth, of course, we are dentists and they are coming to dental clinic, intraoral examination. Okay, these 5 points should be examined before we go next step. Okay, then usually we're going to add some investigation. As you can see, one is a simple psychological test, general health questionnaire or pain health questionnaire or something like that. But simple one, okay, because to rule out psychological issues. And usually we order radiography. As you can see, orthopantomography is usually recommended because this is for screening, okay? So we're gonna screen the bony lesions or fractures or invisible caries or unknown dental cause or something. So orthopantomography may be good for screening. So these physical examination with 5 points and some investigation. Of course, it depends on the case. Sometimes we need to have blood tests for rule out rheumatoid factor or something like that. But at least we need these tests. Okay. So I don't spend a lot of time for examination tonight, but time is limited. But a part of physical examination is something like this. First, general head and neck is, for example, left-sided photo. She may have facial asymmetry. You agree? Facial asymmetry means, the left side is longer than right, or left side is bigger than right. So we just check. And other thing is any evidence of trauma, bruise, any evidence of inflammation or infection. We're going to check any redness or swelling, okay, in this area. The next one is TMJ examination. So we're going to ask the patient to open your mouth or to move side to side, lateral excursion. We're going to check the range. Okay, if it's limited, we're going to check it. And next one is muscles. We're going to palpate, in this case, temporalis muscle and upper cervical muscle as well. This is palpation of sternocleidomastoid. We're going to do palpation for muscle examination. And the bottom one is cervical screening examination. So we just ask the patient, to bend or look up, look down, or rotate. And if they have very obvious limitation or limited range of motion of the neck, we need to think about the referral, because they may have problem in the neck, cervical spine, and this problem cause pain in the face or jaw or somewhere, right? So these are 5 physical examination for comprehensive evaluation. Okay. So in this particular case, what I found is 22-year-old female. Intraoral structure within normal limits, but she has limited mouth opening, almost 10, 20 plus, 22 or 3 mm. And she has palpation tenderness on the right masseter muscle and right SCM and right upper trapezius, as you can see. No palpation tenderness on the left. And what's happening is right masseter muscle is, when I palpate masseter muscle, this palpation can refer the pain to ear on the right side, same side, and to the tooth on the same side. I'm going to explain the details later, okay? It's called trigger point. And there's no palpation tenderness on the left. Then cervical screening evaluation, all within normal limits, okay? No problem. And this is orthopantomography of this case, particular case. And, she had already had the root canal treatment and some missing teeth and some crown bridge, but there is no bony lesions like ameloblastoma or no fractures, sinus is okay, and TMJ looks within normal limits. I mean, there is no obvious remodeling or, the bony changes in the joint, okay? Coronoid process as well. This is what I found by comprehensive evaluation. So now she was referred from ENT. What is your diagnosis? This is the next point. Patient asked me, doctor, what is your diagnosis? So now you can stretch because this is in the middle of lecture, okay? So differential something is not easy sometimes. This is what's happening with me and my daughter. When I went to the beach resort in Penang Island in Malaysia, what's happening is I went to the restroom, okay? And I really didn't understand which one is for gents and which one for ladies, As you can see, W and M look like. And unfortunately, I was in the upper one, so I made a trouble. But fortunately, it was my second daughter, so nothing was happened. But differential is not easy, yeah. But this beach resort is quite nice beach resort, as I have to tell you. It's called Pine Tree Resort. It was nice, except signboard in the fitness gym. Okay, and this signboard is quite cheap, I think. It's just upside down. M and W is just upside down, isn't it? They have to spend the money, I think. Okay, so my provisional diagnosis is myofascial pain of right masticatory and cervical muscles, okay? Because of the palpation tenderness, and I can see I can find the pain referral from the especially masseter muscle. So I don't think she has TMJ tendonitis because there is no palpation tenderness in the right TMJ and no tenderness in the temporalis muscles, right? So this is all of these are, the typical diagnosis for TMD and orofacial pain, okay? Then, discussion. So what is orofacial pain? First, orofacial pain is a form of pain, orofacial pain is a form of pain perceived in the face and oral cavity. And the point is, anyway, these pain inputs are conveyed by trigeminal nerve, one of the two of all of the three branches, okay? Trigeminal nerve is, as you know, the biggest nerve in the 12 cranial nerves. So the innervated area is huge, right? Then let's see prevalence of orofacial pain. Lipton et al. Surveyed more than 5,000 adults in US, and they reported that 22% of adults have experienced orofacial pain during the past 6 months, okay? So it's not a few, 22% of adults. And the most pain was toothache, otherwise dental pain, okay? Problem in the mouth. It's about 70% of 22 adults. And second most is jaw pain, so-called temporomandibular disorders, TMD, okay, about 20%. And third one is others. Others means, you know, other orofacial pain disorders, such as neuralgia, trigeminal neuralgia or something, or such as neuropathic, neurovascular pain. It means, you know, facial migraine or something like that. And psychogenic pain, pain from psychological issues, about few percent, okay? These are what they reported. So, second most is jaw pain, temporomandibular disorders, T from temporal muscle, M from mandible, and D from disorders. So TMD, usually say. So TMD is a collective term embracing a number of clinical problems that involve the masticatory muscles and or temporomandibular joints and associated structure. Sometimes they have problem in the muscles, but sometimes not only muscle, both muscle and joints and other structures as well. Okay, so anyway, if I say TMD, is the pain and dysfunction in the masticatory muscles and temporomandibular joints. Okay, so let's see the details of TMD. This is first evidence-based diagnostic classification for TMD. It's called DC/TMD. DC is diagnostic criteria, okay? And under TMD, there are two majors. One is muscle disorders, you know, diagnosis may be myalgia or myofascial pain or something like that. And the other one is temporomandibular joint disorders, disc displacement, osteoarthritis, subluxation, so on, so on. These are two majors, okay? And also they said there are two minors. One is headache. This headache is not primary headache like a migraine or a cluster. It's a secondary headache. So headache attributed TMD. Headache is caused by TMD problem. So it's a completely secondary headache. And the other minor one is associated structure, means, you know, it's an anatomical abnormality, for example, coronoid hyperplasia or something like that, okay? But anyway, these are minors. So most of the patient may have problem in the muscles or joints. And in this particular case, I think she may have one of the muscle disorders, okay? So what type of pain is the most? This is very interesting, classic report study by University of Kentucky Orofacial Pain Center by Dr. Oacial. They reported primary diagnosis from over 6,000 patients, okay? The most was muscle pain disorders. So in this case, muscle pain disorders of masticatory muscles or upper cervical muscles. And second one is TMJ pain, neuropathic pain, primary headache, others, you know. So anyway, the most is muscle pain. Okay, so in this particular case, my diagnosis was myofascial pain of right masticatory and cervical muscles. But what's the myofascial pain? it's not facial, fascial, okay? A regional muscle pain syndrome in the body that is characterized by trigger points and referred pain, okay? General muscular pain is called myalgia, anyway, any muscle in the body. In the case of myalgia, there is no trigger point and there is no referred pain. Pain is just in that muscles, okay? That's it. But in the case of myofascial pain, which that is characterized by one is trigger points and one is referred pain. And this is, bottom one is very classic. It's called Bible of myofascial pain, written by Janet Travell and David Simons, part 1, part 2. It's a very thick classic textbook. And Janet Travell, the ladies with, it's a President John F. Kennedy, as you know, is the president in 60s. But she was the family doctor of President Kennedy. So he may have a trigger point problem, myofascial pain in some way in his body, I guess. But anyway, this is the textbook. And let's see one by one. The first one is trigger point. What is trigger point? Trigger point is a hyper-irritable site palpated in the muscles. They often say it's a taut band or lobe-like swelling in the muscles, okay? But exact mechanism is still unknown, but they may have very sensitive point or hyper-irritable site in the muscles. And we're gonna check it by palpation. And this figure is from the textbook of Janet Travell, but sometimes we cannot feel by finger because if the person has very thick layer of the fat under the skin, it's not easy to palpate. But anyway, we can find a very sensitive or very hyper-irritable site by palpation. And next one is referred pain. Referred pain is a pain that is felt in the body region remote from the source of pain, okay? So we should check the keywords, source of pain versus site of pain. So for example, in the case of masseter muscle has 2 layers, superficial and deep. And these cross, the black cross is the location of the trigger point. And this red area is the site of referred pain, okay? So what I'm saying is they may have, they developed trigger point somewhere in the masseter muscles and they feel pain in the, for example, upper posterior teeth or lower posterior teeth or ear, inside of the ear on the same side and somewhere in upper temple or upper eyes or something like that. So in this kind of case, that makes clinician, just confused because patients complain, I feel pain in my jaw, but I also feel pain in my ear. I also feel in my teeth, maybe something wrong in the teeth. They often say in this way in the clinic, okay? But anyway, in this kind of case, we need to define which is the source and which is the site. Otherwise, we're going to miss the target of treatment. Okay, so how to evaluate trigger point in the clinic, dental clinic? Okay, the first, find the sensitive point, hypersensitive point. Okay, in this case, I'm palpating right masseter muscles of the patient and palpate for about 10 seconds. Of course, the patient say, oh, it's painful, ouch, or something like that. But continue to palpate for about 10 seconds and ask the patient in this way, any pain besides I'm touching? Then the patient may say, oh, I feel pain in my ear, doc. And she's pointing out ear, right? I'm palpating right masseter muscle, but she's pointing out right ear. It's inside of the ear. We're going to evaluate trigger point in this way. All right? It's quite simple, but if you don't have training, not easy, because it's not usual in the practical session of dental school. Right? Okay, so next one is rule of thumb in the management. So successful therapy is achieved by treating the source of pain, not the site of pain, okay? The target of treatment should be source, not the site. So in this particular case, the patient's complaint toothache first, right? But it may be the site of pain, okay, not the source. And the source of pain is in her right masseter muscle, I think. And she also complained pain in the ear. But the earache, pain in the ear, is also site of pain, not the source. So if go into the site of pain as a target of treatment, we're going to mislead the case, okay? For example, redo of dental treatment, for example, root canal treatment, cannot improve the source of pain in the masseter muscle, cannot, right? For example, procedures in ENT specialist by earache cannot improve the source of pain in the masseter muscle. So the target of treatment should go into the muscles, masseter muscles in this case. This is the point. Okay, about 3 years ago, I had the chance to attend the pain symposium in Singapore, and the guest speaker was Dr. Don Nixdorf from University of Minnesota. Dr. Nixdorf and I were having a training of orofacial pain almost the same time in North America. He's originally a Canadian, so I went to see him. And it was my first time to visit Singapore. And anyway, at that time, Nixdorf introduced very interesting study. The title was Frequency of Non-Odontogenic Pain After Endodontic Therapy, Systematic Review and Meta-Analysis. So they reported 3.4% of patients experienced persistent pain of non-odontogenic origin following root canal treatment. So 3.4% still complain pain after the root canal, but it may have, which has non-odontogenic origin, okay? So it means no problem with root canal treatment itself. Pain is coming from somewhere. And the outcome of non-odontogenic tooth pain is not as rare as commonly assumed. This is their conclusion, okay? So we need to check it if the patient complained chronic toothache, okay? After the successful treatment, usually, right? Okay. And they are doing, in University of Minnesota, they are doing a very big project to review the, non-odontogenic toothache in these almost 10 years now. It's a big project under National Institute of Health, National Institute of Dental Craniofacial Research. Okay. So, a good rule to follow in diagnosing orofacial pain in our daily practices, this is what I recommend. We're going to think about dental pain, so pain from the mouth, proved otherwise, because it's the most, right? Then if it's not dental pain, if it's not toothache, if it's not pain from the soft tissue in the mouth, we're going to think about TMD pain, means pain from the temporomandibular joint or masticatory muscle or both. Anyway, TMD pain, okay? Because this is second most proved otherwise, okay? Then if it's not dental, if it's not TMD, we're going to think about other facial pain disorders such as neuralgia, neuropathic pain, or neurovascular pain, facial migraine or something, and also psychological pain with psychological issues, just like somatoform disorders. Okay, but honestly, it's rare. Okay, it's rare. But anyway, I think we're going to think in this way. So, things to know. When the etiology of a dental pain condition cannot be clearly identified, it is necessary to consider all possible causes, including non-odontogenic origin. So usually it's called non-odontogenic toothache or non-odontogenic odontalgia, okay? The need for comprehensive evaluation and careful diagnosis before irreversible dental treatment is emphasized, or before irreversible dental treatment is repeated, I think. So it means usually problem is in the diagnosis, not in the treatment itself, okay? So we should go back and we should redo history taking and comprehensive evaluation, clinical examination, and we should think about diagnosis is correct or not, okay? I think this is the point, yeah. And if the diagnosis is not established, don't go to the next step. I mean, don't do the irreversible treatment because we cannot go back. Yeah. Okay. Okay, this is, so in this case, you know, in this particular case, patients started to have treatment for myofascial pain of her right masticatory muscles by pharmacotherapy and physiotherapy and so on. And we don't need to touch the tooth for 6, no need. Yeah, this is what's happening in the beginning of this year under the MCO. It was difficult, as you have. Okay, this is the monkeys in the place called Nagano, Japan. You know, as you can see, it's snowing. So it's a winter and they are dipping into the hot spring. You know, they like it, hot springs. And even this kind of monkey, they're going to check the toothache first. Okay, they're going to check it. Then go to TMD and other pain, all right? So thank you so much for your time and patience. We may have question and answer, I think. Is it okay, Dr. Mas?
Yeah, thank you. Thank you very much, Prof.
My pleasure. My pleasure.
So there are a couple of questions here in the chat box. So let me read the first one by Professor Dr. Fuad. Okay, dear Professor Nobu, marginal periodontitis is a very old periodontal diseases classification before 1980. It does not exist anymore in perio classification.
Okay. So I have to exclude.
Yeah. Prof. Fuad, are you out there? Would you like to comment? Or you can't? Okay, never mind. Yeah.
Okay. Sorry about that.
Yeah, maybe Prof. Fuad can type. So, okay, another question is from Professor Kellam. After endo, could they be getting muscle or TMJ pain from having their mouth open for such a long time?
Okay, okay, very good question. But one is, as he said, during the root canal treatment, they have to open their mouth for a long time, again and again, right? It may make the myofascial pain worse. In this case, it's not the cause. I mean, it may be able to perpetuate the muscle pain. So this is one point. And the other point is the root canal treatment caused her myofascial pain. I don't think so. I don't think so. There's no direct relationship between dental treatment and myofascial pain. You know, not only dental treatment, medical treatment as well. There is no direct relationship. So anyway, most important point is, if we do the wide mouth opening again and again for the dental treatment, it may make the patient's pain worse and worse. Okay, so again, the target of treatment should go to the muscles, not the teeth. Yeah, is it his question?
Yeah. Thank you, Prof. Nobu.
Okay.
So two people raise their hand. So the first one is Prof. Fuad. Would you like to ask a question?
Yes.
I think they are not able to unmute themselves.
Yeah. I'm okay now. Can you hear me now?
I can hear, Prof.
Yeah. Thank you, Prof. Nobu.
My pleasure.
Very interesting talk. Yes, you know, in Perio, we are really interested in this problem, and usually we got. I'm working on this in this issue. Also, I receive many patients with this with the TM joint problem. And I want to ask maybe one question from my previous experience when I was in France. I was a postgraduate student, and unfortunately, our the director of the postgraduate student, he complained from severe TM joint problem. And they invite one specialist from Japan at that time, and he did for her the needle procedures, or what we call it, acupuncture, and she got a very good relief. This is one of my questions. Did you consider that this type of a treatment can be used, or can be one of the way to relieve the pain for such a patient? This is number one. Number two, what's your opinion about the night guard? The night guard, when we construct a night guard for the patient who's complaining from this pain, muscle pain, or trismus, or something like that.
Okay, thank you, Prof. First one, the needle therapy. Okay, yes, in the case of myofascial pain, there are two types of needle therapy. One is trigger point injection, recommended by Janet Trabell or David Simons, okay? And the other one is, yes, acupuncture, dry needling, okay? Dry means it's only needle, right? And in the case, for example, from my past training, we were trained to do the trigger point injection. Trigger point injection is, we're gonna directly inject to the trigger point in this particular case, in the right masseter muscle with local anesthetic. In this case, it's a pure lidocaine. I mean, a pure means lidocaine without epinephrine. Epinephrine makes a lot of trouble in the muscles, you know, so necrosis in the muscle. So without epinephrine, pure xylocaine to the trigger point. It's called trigger point injection. And this trigger point injection recommended by Janet Trabell, and we not only dentists, they're going to do it for other muscles in the body, you know. Then next one, acupuncture. Unfortunately, I'm also Japanese, but I really don't know the very concept of the Oriental, the acupuncture therapy. So they have different concept. What I'm saying is with myofascial pain of Janet Trabell, David Simons, okay? They have, as you know, yin and yo or something like that. So they have a very, the scheduled site in the body, and they're gonna put the needle at that site, okay? So it's not to the trigger point itself. They're gonna put the site in the case of Joe here, in the case of headache here, or something like that. And they are using only dry needle, no, no solution, no lidocaine, right? But there are some, so these are two kinds. And I don't use acupuncture because I don't know how to do that. I don't know what that is, actually. But there are some people, especially in University of San Francisco or UCLA or somewhere, they are doing this dry needling to the trigger point. So they put the needle, only needle without solution. And they said it works. There are some evidence by publication. So these are, possible treatment for myofascial pain. But I have to tell you, it's not only needling, we're going to do pharmacotherapy, we're going to do physiotherapy, all of these multidisciplinary treatment at the same time. So, for example, trigger point injection is a kind of the last resort, If it doesn't work, we're going to do that. Yes.
Okay, thank you, Prof. Nobu and Prof. Muhammad for the very enlightening discussion. So we'll move on to the next question. Hi, doctor. How do we go about management of TMD as a GP? Besides pain relief with medication, cold compression, etc., at what point of time that of our intervention do we expect improvement of symptoms? And if not, to refer to an orofacial pain specialist like yourself.
Okay. Today, I didn't talk about the treatment or management itself, but yes, it's possible to manage some, for example, TMD, patient with TMD. And usually we may have these three. One is home care program, including self-care and so on, okay? We're gonna instruct the patient how to do that, jaw stretch exercise and so on. And second one is, Prof. Faoud also asking about the night guard, spring. Sorry, I'm gonna tell. And one is home care program, one is occlusal splint, if they have bruxism, grinding or clenching. And third one is simple physiotherapy, not by physiotherapists. Simple physiotherapy is by a dentist or by patient themselves, okay? And home care program includes usually medication because they don't need to come to the clinic. We're gonna prescribe and they're gonna take medication. So these medications usually, one is non-steroidal anti-inflammatory drug or paracetamol or some painkillers, and also some baclofen type of muscle relaxant, so on. Okay, so we're gonna provide these three: home care program, splint if they have grinding or clenching, and simple physiotherapy. And it's possible to provide even as a general practitioner. Okay, then if it works, it works, it's okay. But if this so-called initial therapy for TMD doesn't work, I think it's better to discuss with the patient and to refer the patient to a specialist, I think. Because some TMD may have comorbid issues. Comorbid issues means, they came to see you as TMD, patient with TMD, but they originally has primary headache, such as migraine headache, or they have something like that. And these comorbid issues aggravate each other. So in this case, it's very difficult to manage, So in this case, it's better to refer to the specialist. But what I'm saying is, initial therapy should be tried in your office. Yes.
So conservative treatment first.
Yes, all conservative. All conservative first. Yes.
So there's a question. Hi, Prof. I sometimes prescribe occlusal splint for my patient to overcome bruxism. In your opinion, is there a thickness limit to avoid TMJ pain in the future? My patients mostly are special needs patients, so they are concerned that sometimes they might not be able to identify or express or notify the TMJ pain.
Okay. As for example, as Prof. asked me about splint, occlusal splint or night guard, whatever, the question of these oral appliance, lots of types. So I just say oral appliance, okay? The question is by John Rue of Texas, all of the types of splint may have over 70% of successful rate, okay, from the previous report. So it means we really don't know which one is good and which one is not, or, whatever, if they put something in the mouth, it makes over 70% of successful rate. So, for example, Dr. Dao or University of Toronto once in 90s, she said, we really don't know about the exact mechanism of splint occlusal appliance. So we really don't know what's the exact mechanism, but we are using. Okay, lots of debating, still debating, but I think if they have, obviously, if they have bruxism, grinding or clenching habit, I usually prescribe occlusal splint, yes. But if they don't have grinding or clenching habit and pain, I don't make it. I don't prescribe usually. So if they have grinding or clenching habit, at least occlusal appliance can avoid a further attrition or facets or further hypersensitivity or something like that. So what I'm saying is we still don't know exact mechanism of occlusal splint. So occlusal splint is not definitive treatment for TMD. It's not one of multiple approach, I think. Yeah. Okay.
Okay. All right. So, okay, there's another question. May I ask how exactly do we manage the trigger point?
Okay. In the case of trigger point, something is a bit more complicated than initial therapy that I told you now, okay? First, we need to release the trigger point. So we're gonna do medication first, pharmacotherapy, okay? Not only painkillers. We need to prescribe something like a baclofen. Baclofen is classified as muscle relaxant, but actually it's a GABA-oriented drug, so more centrally, active drug. We need to use this kind of drug. And not always, but sometimes we're gonna use antidepressant, not for depression, for chronic pain, okay? So we have some bit more advanced pharmacotherapy. And second one is physiotherapy, must. Physiotherapy means usually, I'm working with physiotherapists, UIT and Punchakaram, but they're gonna do a bit aggressive physiotherapy for myofascial trigger point if they have, right? And it works. Actually, it works. And third one, as I told you, if it doesn't, reduce the pain, we're going to think about the trigger point injection or dry needling or something like that. Okay, but usually the patient like that myofascial pain, chronic, they may have some kinds of psychological issues. I mean, they are very healthy people, but they may have some kinds of problem like, depressive state or anxiety or something like that. So we also have to take care of these psychological issues as well. And we are dentists, so me either. I cannot control the psychological issues. So I need to ask the help of clinical psychologists next door, in my case, from the Faculty of Medicine. Yeah. So at least dentists and physiotherapists and clinical psychologists, not psychiatrists, clinical psychologists, we're going to make a team and we're going to do multidisciplinary approach, multiple approach for this kind of chronic muscular pain, chronic myofascial pain. Yeah, so it's not easy in the office of GP, I think.
Okay, all right.
Yeah.
I think Prof. Arshad Malik raised his hand. So do you want to ask a question? Prof. Arshad Malik?
Thank you. Thank you, Professor Nobis. I'm Professor Arshad Malik. I'm basically maxillofacial surgeon and I'm principal of a dental college as well here in Pakistan. It's a wonderful presentation by you, gentlemen. And it's so lovely that you have covered approximately every aspect of myofascial pain. And especially with comments to the baclofen use, it is a wonderful drug. And we in Pakistan here, we have made a head and neck pain clinic where we have added neurosurgeon, psychologist, ENT, and maxillofacial surgeon. These four people generally we use sit together, and for the complicated case we used to evaluate by our mutual discussion. This is our idea in Pakistan, that we have made an head and neck pain clinic, and we all four consultants we sit together on every Friday and we go for the differential diagnosis. My question with your presentation is that what is your idea about the use of TENS, use of soft laser, and use of steroids, especially depots, in your clinic with reference to all the myofascial and with reference to TMD as well? That what is your experience with TENS, with the soft laser, and with using of the steroid acting steroid lights depots, and where you suggest that? Thank you.
Okay, I only know about the one is TENS, okay, transcutaneous electric nerve stimulation, and you said soft laser, okay. I have experience with these tools with physiotherapists. Okay, now we are using also ultrasound with this, okay. So ultrasound, TENS, and soft laser. Okay, TENS is transcutaneous electric nerve stimulation. It is good to stop the pain inputs, okay. So we are using to stop the pain inputs. So it's different with myomonitor or something in the past, we are using for the pain. And it works, yes, as you said, doctor. And the soft laser, once I was using with my team, the colleague, about before Malaysia, so about 20 years ago. And my conclusion is, and also the report from the publication, I really don't know the exact mechanism of soft laser. I was using I was put the soft laser to the trigger point, okay, directly. And sometimes it works, but sometimes it doesn't work or something like that. So my conclusion is I still don't know it works or not, but it might be possible because I don't know exactly, but as you know, lots of development in the laser, diode or something like that. So I think it's better to follow that. And the third one, you said steroid, am I correct? Steroid. Okay. Yeah. In the case of the severe degenerative joint disease, okay, I mean a developed degenerative joint disease means if it's simple osteoarthritis, I don't use steroids, but if it's developing osteoarthritis or something, sometimes I use steroid. Yeah, I mean the pills for short term, for a few weeks or something like that. Yeah. And I don't inject steroid to the joint. Some oral surgeons may be able to do it to the joint, but I cannot do it in the joint, So I just prescribe, yeah, in these cases. All right. Okay. Thank you so much.
Thank you, Prof. Nobu, for the answer. Okay, our next question is, will the myofascial pain recur after site injection treatment? If yes, normally how long will the treatment normally last? Do we need special training for site injection? Is there any side effects?
Okay. Okay. Maybe you're asking about myofascial trigger point injection. Trigger point injection is not just once, we repeat sometimes, okay? And the other thing is it's by needle and pure local anesthetic, pure lidocaine or procaine. So basically, there is no severe side effect. We just put 1 or 2 cc in the muscle. Okay, that's it. Then the other thing is, of course, if they have allergy to any local anesthetic or something, we don't do that. But if they don't have it, we do that. And the next question is, oh yes, we need a training. We need a training means we need a training how to do that. How to do that to the especially masticatory muscles, and also upper cervical muscles, sternocleidomastoid mastoid, upper trapezius. We can do it if they have trigger point. Okay, so of course we need to have training. But honestly speaking, I think, for example, trigger point injection to the masseter muscle is easier than inferior alveolar nerve block. I think, it's right here. So inferior alveolar nerve block is more complicated, more difficult, I think. Yeah, but of course, need a training. Yes.
Is there any side effect?
Actually, if they don't have allergy to or reaction to local anesthetic, usually no side effect. Yeah. Okay. Point is, the dose is minimum. 1 cc, 2 cc enough.
Okay, so another question, dear Prof. Nobu, in some patients with chronic parafunction, they may not present with tenderness to palpation. Do we still proceed with an occlusal splint?
Okay, it depends on the the objectives. I mean, if they don't have palpation tenderness, means if they don't have pain, for me, I think I don't need to prescribe occlusal splint. Yeah, but if you want to stop the grinding or clenching, bruxism, the story is different. So what I'm saying is, if they don't have pain, if they don't have dysfunction, I don't provide occlusal splint because bruxism is a kind of habit. I mean, it's not disease itself, right? So I think it's better to check the any psychological issues or stress or something like that, or I think it's better to control these contributing factors, because even if you issue the splint, they can grind or they can clench on the splint, from my understanding, and sometimes they can break it up. So honestly speaking, we cannot stop the bruxism. We cannot, if we don't use very strong sedation or something. So sorry, I cannot make I cannot clear the point, of the question. Yeah, but that's what I'm thinking.
Okay, right. I suppose it's also preference, operator's preference, yeah, because when I was doing my postgraduate training in Australia, we do a lot of Michigan splint for patients with the MD. So as you said, sometimes it works, sometimes it doesn't. So it's one of the treatment options. The others are Botox, I think.
Yes.
Yeah, it's I've seen it done a lot of times as well. And of course, physiotherapy, as you said, medications and surgery. Yeah. So there was the question about that injection treatment. We missed. Will it recur after the injection treatment? Is it going to reoccur?
Okay. Usually, what we are doing is, after the trigger point injection, for example, we can, if we can reduce the pain, we're gonna, do more. We're gonna up the physiotherapy. We're gonna do it more, because now pain is less and less. So if the pain is less and less, we're gonna bring up the physiotherapy more and more. Because if they have pain, we cannot stretch the muscle, because it's painful, right? So we're gonna reduce the pain first. Then we're gonna start to stretch more. So what I'm saying is, after the trigger point injection, treatment is done. No. We need to do physiotherapy more than before. And also we need to prescribe, to reduce as much as possible, reduce the pain as much as possible, right? So what I'm saying is, trigger point injection is also, it's not the final one. I mean, just to reduce the pain. Yes.
Okay. So one last question here. Is there any role of stress and psychological issue in TMJ problems?
Yes, it's good question. It's not easy to say. From the report, the TMD patient may have some high scores in the psychological test, or GHQ, PHQ, whatever, SLC 90, whatever. Usually they have. But what we cannot say is, this is the result of chronic jaw pain or facial pain, or this is the cause of chronic facial or jaw pain. We cannot say so. We cannot say in this way. We really don't know. So in a sense, if they have chronic pain, they're going to be depressed, they're going to be stressed out, so on, so on, so on. But sometimes, the patient may have, sometimes we definitely need the help by a clinical psychologist because of the psychological issues to relieve that TMD pain. So what I'm saying is, it's not so clear, but psychological issue must be one of the contributing factor for pain, right? One of the contributing factor. And just like habits, bruxism, it's one of the contributing factor. So what we need to do is, we need to delete most of these contributing factors, as many as possible. That's all we can do. Yeah. But the problem is, in the case of psychological issues, it's not easy. It's easy to say that, but it's not easy to do that, because we cannot control, actually. We dentists cannot. We can help, we can support, but we need a specialist to control the psychological issues. Otherwise, it's impossible, I think. Yeah, I mean, because I had a lot of cases that struggled, you know. That's all I can say.
Do you think it's worth asking the patients during history taking that, is there any recent episode of stress or that the patient might face difficulty in life, so that can also give an idea whether there is a component of stress or psychological issues there.
Yeah, but the problem is most of my patients in my clinic say, yes, you know, I have stress, of course. So most of 90%. So okay, at that time usually, okay, me too. I have stress in this kind of clinic, you know. So yeah, this is what's happening.
All right. Okay. Okay. There's a question. How to help patients that have limited mouth opening that need jaw exercise, but will experience muscle pain when opening the mouth. Young patients that have issues to sustain for mouth opening only 14 mm. He still have all the teeth up to third molar. Post radiotherapy for head and neck. Tried massage with warm towel, but still have the same pain. Usually patient unable to complete the jaw. I think patient unable to open the jaw completely.
Okay. You said it's a post radioactive therapy.
Yeah, in the
that right. Okay. Yeah, I don't have many cases, but I have some experiences post, radioactive therapy, especially upper pharyngeal or cancer or something like that. In that case, the problem is after the radioactive therapy, they have limited opening, usually because of because of the muscle necrosis by radioactive therapy. So in that case, if they have, it's called contracture. Contracture means muscle cannot stretch anymore, cannot, right? So if they develop the contracture, we cannot fix it by conservative therapy. Even aggressive physiotherapy cannot. Can help a little bit, but actually cannot. So what I'm saying is, during the radioactive therapy, I think they should start something like a exercise at the same time. Otherwise, after the therapy, we cannot help that because of contracture. And if we need to do something, if they cannot open the mouth, cannot eat, cannot drink, only surgical procedures, cut the muscle, something like that. Only surgical can help the patient. So we need to discuss with the surgeon. That's all we can do.
Yeah, do you think using the Therabite would help?
Therabite is good for initial therapy of TMD. Yeah, not for post-radioactive, no. It's already developed, So me too. Usually, I have some cases, but I could help them. No, cannot. I still remember one patient. I don't know exact location, but the Tonsing Hospital in KL referred the patient. And this old gentleman had the radioactive therapy because of cancer and somewhere in the neck, pharyngeal or laryngeal. And he came in, and at that time, mouth opening is totally limited. And I tried some conservative therapy, including physiotherapy, so on, ultrasound, TENS, whatever, but cannot increase the range of motion. And the point is, he doesn't have pain. He does not. The movement is limited, but no pain, okay? So it means, I think it's not myofascial pain, it's not myalgia, it's a contracture of the muscle by radioactive therapy. So yeah, I could not help him. Yeah, I still remember that.
Okay, there is no new questions.
Good.
Okay, so I think I have one last question. When do you think that surgical intervention is indicated?
Okay. Sometimes we need the help of oral maxillofacial surgeon. Yes. What I'm saying is, we tried initial therapy, home care program, occlusal splint therapy, pharmacotherapy, physiotherapy, and after the initial therapy, usually it's called 6 weeks program. It takes about 6 weeks. We're gonna re-evaluate the patient. And if we cannot help the patient after the 6 weeks program, I'm gonna think to refer to oral surgeon for surgical procedures, or I'm gonna think about advanced pain management. It's quite developed, established in Selayang Hospital by Dr. Cardosa in the case of Malaysia. And that's what I'm thinking usually. Yeah. So what I'm saying is initial therapy, conservative therapy first. Then if it doesn't work, we're gonna refer to oral surgeon. Yeah. But if it's opposite, it makes problem. Opposite means surgical procedure first, then try to initial therapy. It doesn't work.
Okay, all right. Thank you very much, Prof. Nobu.
You're welcome.
All the questions have been answered. So I would like to pass this session over to Professor Dr. Muhammad Ibrahim for his closing remarks. Thank you.
For excellent in moderating these sessions. And we hope that the audience tonight will be benefit from Dr. Yoshinobu experience and sharing his experience with us tonight. So on behalf of section 15, I would like to thank you, Associate Professor Mas for moderating this session, and also to Associate Professor Dr. Yoshinobu Shoji for sharing his experience with our participants of our webinar tonight. May we meet again in future. So moving on from now, we for the next month, October sessions, so we have a speaker. This time we were talking about public health. Okay, public health. This is quite a while we have not talked about public health. She'll be talking about motivational interviewing in dentistry, making every contact count. Okay, so the speaker is Associate Professor Dr. Budi Aslini Sabri. She has BDS from UC Malaya, and then MDSC, MDCPH, and DRPH from Queen's Mary, London. So she'll be talking to us in 2 weeks' time on the 6th of October at 9, same time, 6th October, same time. So we'll meet you again for our next webinar in October. Till then, have a good rest, and thank you for joining us tonight, and thank you all. Also our speaker, and also Professor Ashad Malik, who has joined us tonight, and also Professor Dr. John Ling, our registrar, who has also joined us tonight in our acting. With that, I think I would like to thank you all of you for joining us. Till we meet again in our next webinar 2 weeks from now. Thank you and good night, all. Thank you.
Thank you, Prof.
Thank you. Thanks, Prof. That was good.
Thank you. Thank you.